We'll now move on to our third acyanotic heart disease, hypertrophic obstructive cardiomyopathy, or HOCM or HOCM. Let's talk about what's going on here. Pathophysiology of HOCM is you have an autosomal dominant disease that causes upper anterior septal and anterior left ventricular free wall hypertrophy. This is the left ventricular free wall that's anterior, and this is the upper septum. Alright, this is what it normally looks like. Now look what happens. Look how thick it gets. The left ventricular free wall anteriorly and the upper part of the septum, they get massively hypertrophied. And it causes a diastolic dysfunction. Because remember, when you hypertrophy muscle, it has trouble relaxing. Important to note, this condition is not a result of excessive afterload. Remember, hypertensive cardiomyopathy is concentric. This is asymmetric. It's not the whole left ventricular wall is hypertrophied. Some parts are more hypertrophied than others. Common presentation, as we saw in our question before, we have sudden death in young athletes. Very, very classic presentation. So if you haven't heard of this before, this is a very key concept associated with HOCM. And I'm going to try and break it down and make it a lot more understandable for you. It's called systolic anterior motion. Okay? This worsens the existing obstruction of the left ventricular outflow tract. So let's talk about this. So we have this left ventricular outflow tract here. Look how nice and wide and open it is, right? Left ventricle can pump into the aorta without many problems. But here, look at how this large septum has caused a major narrowing of this outflow tract, right? So that's going to decrease the amount of blood that's able to flow into the aorta. But there's also more problems that happen as a result, and this is called the Venturi effect. When you have a narrow outflow tract because it's hypertrophied septum, the blood going through is going to shoot really quickly past this small obstruction. Just like if you try to take a hose that's on with water and narrow it, the water starts going faster. The same thing happens. You get a faster flow of blood through this obstruction. And the problem is that when you have a very high velocity blood, you don't really have as much of a pressure exerted on the walls. So you have a decreased pressure inside of the left ventricular outflow tract in the early part of the aorta. And because there's so little pressure here, this valve right here, the anterior valve or the mitral valve, is going to be pulled in this way because of the lower pressure. There's higher pressure here and there's lower pressure here. And as a result, the valve is going to go from high pressure to low pressure because of the fast velocity of blood going through here, and it's going to narrow this even more and cause even more of an obstruction. And that's called the systolic anterior motion of the anterior mitral valve. So hypertrophied septum narrows the outflow tract, resulting in decreased pressure distal to the obstruction. We just talked about that. The Venturi effect is when high velocity of fluid results in decreased pressure, so it's moving too quickly to exert a pressure. And this decreased pressure results in a systolic anterior motion or suction of the anterior mitral valve leaflet. So it's called suction of the mitral valve leaflet due to the pressure gradient causing more flow obstruction and decreased cardiac output. So this, in combination with the hypertrophied septum, can cause problems for patients who have this disease. And as you can tell, there's another mitral regurgitation going on because this valve is being pulled away, so there's going to be an opening between the left ventricle and left atrium. There's also diastolic failure we talked about because the heart is so hypertrophied it can't relax. It can contract very well, but it just can't relax. Hypertrophied the left ventricle and septum are stiff and non-compliant, and they're very difficult to fill with blood. And that can also cause more problems because you already have an obstruction. If you can't fill with blood, that's even another reason to decrease cardiac output, as you see here. Tachycardia also. The reason why exercise causes so many problems, you get tachycardia, and tachycardia reduces the filling time of the heart. It decreases diastolic filling time, and that will worsen the decreased cardiac output and cause major issues. Another important aspect is insufficient coronary blood flow. If you have an outflow tract obstruction, then the coronary arteries which come off the aorta aren't going to get enough blood flow, and you'll have damage to the heart, ventricle, heart wall, and atrial walls as well. And another thing is that this hypertrophied heart over here needs increased blood supplies, increased myocardial oxygen demand, which can't be met with this outflow tract obstruction. So you can get angina because you're not supplying the heart properly with oxygen and blood, syncope because of decreased forward flow, and arrhythmia because of damage to the electrical fibers in the heart. You should have obstruction of cardiac output by this systolic anterior motion and the septum, causing decreased coronary blood flow, and also supply and demand mismatch. You cannot meet the oxygen demand of the hypertrophied cardiac muscle because of how thick the muscle is. Let's talk about some signs and symptoms of HOCM now. First sign that we should talk about is angina, which we've talked about before. You can't supply the heart properly with blood, and the heart starts having ischemia. Dyspnea, because you cannot meet the demands of the body through this narrow outflow tract, you can get exertional dyspnea. Syncope, same reason. If you don't have output of the heart, you won't get enough blood to the brain, you'll pass out. So due to sudden exacerbation of left ventricular outflow tract obstruction, such as exercise tachycardia, and you can also get ventricular arrhythmias. So why does this happen? So you can get a ventricular arrhythmia because you have decreased blood flow in the coronary arteries, causing ischemia of the electrical tissues, leading to ventricular arrhythmias, which can lead to syncope. So there are two different reasons to get syncope, the outflow tract obstruction or an arrhythmia. And it's a major risk factor for sudden death if you have a history of syncope from ventricular arrhythmias such as ventricular tachycardia or ventricular fibrillation. Palpitations you also get because of the sensation of heart beating in the chest. That's a definition. You get it because you're decreasing blood flow to the heart and causing arrhythmias to present and form. Carotid pulse. So this carotid pulse is very interesting that you'll notice with HOCM. The carotid pulse is how the blood flows from the aorta into the carotid arteries. And what happens is you get a short upstroke because of the rapid movement of blood into the carotids. You get a bifid peak. This is the key feature. The bifid peak is due to the obstruction lessening and becoming worse again and lessening again while the blood is flowing through the left ventricular outflow tract. So due to the intermittent obstruction, you're going to get a bifid peak. So it's going to go up, come down, and go up again like a camel hump. And it'll be very quick downstroke due to the high velocity of the blood. S4. Why do you get that? Remember, all hypertrophied hearts get S4 because of the contraction of the atria. Blood from the atrial contraction hits the ventricular walls and causes an S4 heart sound. The murmur you get, this is classic. Systolic ejection murmur at the left lower sternal border at the forced intercostal space. You have to remember that for HOCM. At the forced intercostal space is where this obstruction is going to happen, and that's why you're going to hear the systolic ejection murmur. Another key feature is how the murmur changes with different maneuvers. So anytime you have a murmur in hypertrophic cardiomyopathy, it can get better or worse depending on how much blood is found inside this left ventricle. So if you have increased preload in this left ventricle, what you're going to end up doing, actually let me show you this on a pen. When you increase the amount of blood in this left ventricle, that blood's going to push the septum this way and open up the outflow tract of the left ventricle. So if you push the septum away, there'll be more space for blood to go. That's why increasing left ventricular preload will help decrease the amount of murmur caused by the outflow tract obstruction. But however, if you decrease the preload, say there's less blood in here, now it will go the other way. It will go this way and narrow the outflow tract even more and cause further problems. So murmur intensity increases with decreased preload because the septum will move towards the left ventricle and close the outflow tract further, and decreases with increased left ventricular preload or left ventricular afterload. Remember, the more afterload, the less blood gets pumped out, so you'll have more preload as a result. And this will cause the outflow tract to open and allow more blood to pass through. So examples of things that decrease the left ventricular preload, second stage of Valsalva, when you're straining and squeezing. And what happens is that because you're straining and squeezing, the blood cannot flow back to the heart and you decrease preload, worsening the obstruction. Tachycardia, remember we talked about this. You decrease the amount of diastole time, so you have less blood inside the left ventricle, which will worsen it, and that's why you get problems during exercise. Sudden standing nitroglycerin, all of these decrease preload, and increased left ventricular preload from squatting, lying down, hand grip. All of these will either increase left ventricular preload directly or by increasing afterload, and these will decrease the intensity of the murmur. Diagnosis is very clinical based on symptoms and murmur findings and history, and maybe even syncope episodes, but it's confirmed with echo. Now let's talk about the treatment. The treatment is beta blockers. This is a very major treatment for maintenance for these patients because it will increase the amount of blood flow into the left ventricle during diastole because you decrease the heart rate. Remember, we talked about how decreasing the heart rate will cause increased time for filling, because conversely, increasing the heart rate causes decreased time for filling. So by decreasing the heart rate, there's a longer time to fill, less obstruction because the septum is moved away from the outflow tract. So you decrease the pressure in the left ventricle during exercise, and you'll have decreased contractility of the heart. So when a patient's exercising, there won't be as much contractility in the heart, and you won't have as much blood leaving, which will allow the left ventricle to pump into its outflow tract. Beta blockers also reduce the pressure gradient between the left ventricle and the aorta. But they'll be doing that by decreasing the amount of wall tension and decreasing the contractility force inside the left ventricle. That'll cause decreased myocardial wall tension and a decreased Venturi effect because you'll be opening up the outflow tract. So beta blockers are very important for multiple reasons in hypertrophic obstructive cardiomyopathy. Also, you want to make sure you avoid drugs that decrease left ventricular preload. You want to avoid them completely. These include diuretics, nitrates, and ACE inhibitors. All of these, if used, will decrease the preload to the heart, and you do not want to do that because you will worsen the outflow tract obstruction. You can also put an implantable cardioverter defibrillator into the heart too, because of the risk of syncope and arrhythmia, and this will help prevent the sudden death happening in the patient. So if you have a history of syncope or cardiac arrest, you're a candidate for placement of an implantable cardioverter defibrillator. Also, if you have a family history of sudden death. So these are very important indications to get a defibrillator in place, and this could be a life-saving measure and a life-saving treatment. Avoid competitive sports, as we mentioned, but the key thing here is that mild exercise should be performed. So never avoid mild exercise, but do avoid extreme competitive sports. So now we have our next acyanotic heart disease, vascular rings. So let's talk about what's going on here. This is when you have an abnormal embryologic development of the aortic arch, causing a double aortic arch. So you have one right here and another one right here. But the problem is, look what happens. They wrap around the esophagus and the trachea. So this wraps around these two, causing compression, and this is where the symptoms arise. So it presents very early in life, less than 1 year old, because this is happening so early. And as you get more blood inside the aorta, it's going to start compressing these structures more and more. So some symptoms of tracheal compression. You have inspiratory and expiratory stridor. Stridor means that loud, harsh sound that you get whenever you're breathing in or out. And that's going to happen because you have compression of the trachea, and you're going to try and breathe in by sucking in air and pushing it out. And it's improved with neck extension because you'll be opening up the airway slightly to help with breathing. Wheezing, same reason because of the compression. Coughing because of the compression, and respiratory distress as well because of the compression of the trachea. Now you get some esophageal compression symptoms as well because the esophagus is found posterior to the trachea inside of the chest. You get dysphagia, which means you have trouble swallowing because everything's going to get stuck because of this double aortic arch, and regurgitation and vomiting because of the inability of food to pass down. So the diagnosis is echocardiogram and the treatment is surgery.